another important part of small bowel, conditions or surgical conditions of small bowel, that is called intussusception. But many of the students, they already have a very good knowledge here. I'm sure about it because they have already done this in pathology. Okay, so just enjoy the class. See there, the meaning of intussusception is it is the invagination of one portion of the bowel into the lumen of the immediately adjoining bowel. Or you can also call it invagination of proximal segment of the bowel into the distal one, or telescoping a proximal segment of the bowel into the distal one. Whatever way, okay, you can answer, it is up to you, but the meaning should be there. And always, okay, this is the way to study rather than mugging up the thing. Okay, if you mug up the thing and if you forget the first word, everything will be forgotten after that. This is the disadvantage of mugging the things. Yes, in medical life we need to mug up certain things. I'm not saying that, but try to understand it, try to answer in your own word, and that is always acceptable. The most common form is the result of an origin in terminal ileum or the ileocecal valve, resulting in ileocolic intussusception. Ileocolic intussusception. Please mute yourself. This ileocolic intussusception is the most common one. That means ileum is going into the colon. In the absence of treatment, this condition is usually fatal. Okay, it is very common in children, and if we fail to diagnose this in time, that children may develop perforation of the bowel. In the beginning, ischemia occurs, then later on, even perforation may happen, and that can kill the child. But there are certain signs and symptoms by which we can diagnose it in time. Now, the invaginated segment is called intussusceptum, and the segment which is accepting that invaginated segment is called intussuscipiens. Okay, so these are some of the important questions from the MCQ point of view: intussusceptum and intussuscipiens. So the invaginated segment, or the segment which is going inside, is intussusceptum, and the segment which is the engulfing one, or which is the accepting one, is the intussuscipiens. Now there is one problem here I already talked about. Mesentery and the blood vessels become involved with the intraluminal loop, and they are squeezed within the intussuscipiens, and this is the most important mechanism for ischemia. Okay, they are twisted, they are squeezed. Okay, there is obstruction of the blood supply to that part which is going deeper inside, and because of this, ischemia, necrosis, and perforation are quite common. Venous congestion is a major factor both in symptomatology and in the characteristic presence of blood in the stool. The venous congestion also occurs because of the same way, isn't it? There are mesenteric vein and mesenteric artery. So those veins are congested. There may be bleeding into the lumen of that intussusceptum, and that blood may come out in the stool. We call that red currant jelly type of stool. Red currant jelly type of stool. Now, this is one of the important question which is asked in many MCQ exam in the world. Red currant jelly stool is seen in which of the following condition? And the answer is intussusception. Okay, we'll talk about that again in the clinical feature. Now, what are the types of intussusception? See there? Now, there are a number of types of intussusception which are as follows. One is ileo-ileal. Ileum invaginates into the adjacent ileum, or a proximal part of the ileum is going into the distal part of the ileum. Ileo-ileal. Ileocolic, ileum is going into the colon. Okay. Ileocecal and colocolic, just the terms are important here. Proximal is going into the distal. That's it. Now, what are the causes? Isn't it? We like to know the cause. What may be, producing this type of condition called intussusception. Now, let me give you a concept here. First, if there is something into the lumen of the bowel, okay, on the mucosa of the bowel, then it may act as a source of intussusception. Probably there may be edema, okay, as a result of any inflammation. Those edema, because of the gravitational effect, okay, now they may start to invaginate inside or distally. So just think like that. Now see there, often large Pear's patches are noted at surgery. Now where are Pear's patches present? Where are they normally present?
Sorry, in the ileum and small amount in jejunum.
Exactly, they are mainly present in the ileum. Okay, they are the hallmarks of ileum, and they are the collection of the lymphoid follicle there. So in many GI infection, these Pear's patches are involved. Okay, one of the important example here is adenovirus. This adenovirus infection is quite common. This is a type of DNA virus actually. It can infect many parts of our body, respiratory tract, GI tract, and even the conjunctiva or even the urinary tract are infected by adenovirus. So by causing infection, it may lead to enlargement of the Pear's patches, so which create an axis, or you just say, remember, which create an area of edema, and that area will act as a part of the invagination. Okay, so it just start like that. Another one is polyp or Michel's diverticulum may also predispose this condition in a similar way to the enlarged Pear's patches. So they can also act like a source for intussusception. And another one is HSP, Henoch-Sconleon purpura, in case of a child. It is also one of the common diseases in children. You already know those four important features of HSP: rash, GI tract involvement, renal involvement, and arthritis. So this GI tract involvement is a point here. Okay, the mucosa of the GI tract may be affected, and that can just act like a start point for intussusception. Now, how common it is and what are the common age group? So commonly, the children are between 5 and 18 months. So these are very small kids actually, okay, less than 2 years, and boys affected twice as much as girls. So how the child comes to the hospital, or how the child is presented to the hospital now? See here. So this is a young boy which keep on crying vigorously. Okay, and the the parents are very, very disturbed because of this, and they are too much worried as well. So to probably at the middle of the night or in the early morning, they bring their kid to the hospital, and the kid is continuously crying in front of you also. And during that time, the kid is pulling both of his leg upwards into the abdomen. Okay, and the child looks a bit pale because of continuous crying also. This is a typical case of intussusception. There are so many other differential diagnoses which makes that baby cry, but this is a vigorous type of cry. Okay? This cry occurs because of the pain in the abdomen. The incidence is about 2 per 1,000 live birth, and is the commonest cause of intestinal obstruction in a child aged 3 months to 6 years. Okay, and there is often a pronounced seasonal variation suggesting an underlying viral etiology like adenovirus and even the rotavirus have been suggested. So these are some of the important epidemiological points regarding intussusception. Now look at the clinical features. There is variability of the presentation, thus a high index of suspicion is required. Of course, a lot of differential diagnosis can exist there. That's why high index of suspicion is necessary. Talking about clinical features of intussusception. Intussusception is quite common in children less than 2 years of age, and mainly they are the male babies. Okay, so how they present? They present with severe pain in the abdomen, and because of that, they cry a lot. Okay, this is an intermittent type of pain because this occurs as a result of intestinal obstruction, and because of this pain, this kid they scream, okay, and they look quite pale during the time. They pull both of their or draw both of their legs up towards the abdomen, and then they cry vigorously. And parents are very worried why the kid is crying like that. They run towards the hospital with the kid any time of the day or night. Okay, there are lots of differential diagnosis, so high index of suspicion is necessary. uh, and these spasm they occur at the interval of about 10 to 15 minutes, lasting 2 to 3 minutes, and increasing in frequency after that. So they occur at the interval of 10 to 15 minutes, and each of the episode lasts around 2 to 3 minutes, and during that time the child cry a lot. Now, what are the other clinical features? Here, vomiting is an early symptom in this case. Okay, vomiting is an early symptom, and then there is passage of the blood or mucus per rectum, which is known as red currant jelly, but this can be a late feature. Now, why this is a late feature? Let me explain this. It occurs because of venous congestion, and that venous congestion occurs a little bit late, never in the beginning, because there should be a twisting of those blood vessels which are present in the mesentery. Then only that thing happen. It takes time. The sausage-shaped mass is palpable in most cases, often in the right upper quadrant, not in the right lower quadrant. This is in the right upper quadrant. A mass is not always palpable in ilio-ileal intussusception, or if it is under the costal margin. So it is way up under the costal margin. So in that case, it may not be palpable. So sausage-shaped mass may be there. This can also be asked as a question in the exam. Okay. So please mute yourself. Now, during examination, what we get during the rectal examination, what are the findings? The rectal examination reveals, a mixture of bright red blood and a mucus, which is described as red currant jelly. Okay, remember this term, red currant jelly, which is seen on the examining gloved finger, okay, of the doctor who is doing that examination. This is known as digital rectal examination or per rectal examination, and you of course wear a glove there, and on your gloved finger, bleeding is seen along with mucus, which is known as red currant jelly stool. Very rarely, the tip of the intussusception also can be felt if it is going way distally, but usually, it is not going that far, so the tip is not usually felt. If intussusception is neglected, in less than 24 hours, the child may be intensely toxic, have a distended abdomen, and exhibit feculent vomiting. Now, this distended abdomen, intensely toxic, and feculent vomiting are a feature of large bowel obstruction. Okay. On top of that, small bowel obstruction is also, there, and then peritonitis has already occurred because of the probably rupture or perforation or migration of the bacteria there. So this case should be diagnosed a bit early and managed accordingly. Now, what are the differential diagnosis of intussusception? Gastroenteritis. Gastroenteritis is the term for diarrhea. Okay, this is a medical term for diarrhea or diarrheal illness in child. Other causes of intestinal obstruction, whatever they are, because they may manifest similarly. Constipation and even hemolytic uremic syndrome can be considered as a differential diagnosis in the child. Now, hemolytic uremic syndrome, can you tell me what are the three things in hemolytic uremic syndrome? Yes. What are the three things together?
Sir, we have got the microidiopathic hemolytic anemia, the thrombocytopenia, and the acute renal failure.
Yes. Now the point is why hemolytic uremic syndrome can be considered as a differential diagnosis. Nothing is matching there. This is a case of intussusception, and that is a case of anemia, okay, then thrombocytopenia, and then renal failure. Now the point here is how this hemolytic uremic syndrome start. Okay, you have to go there, and those are usually dysentery, okay, caused by Shigella dysentery organism, or a bit of blood in the stool caused by EHEC O157H7. That is the name of the bacteria, enterohemorrhagic E. coli O157H7. So in this case also there is blood in the stool. In this case also there is abdominal pain. So these things matches with each other, that's why it is considered. Sometimes examiner may ask you question like this just to make sure that whether you know these things or not, whether you have concept of these things or not. That's why. Now let's talk about the investigation. Plain abdominal radiology may reveal features of obstruction, and those features of obstruction we have just discussed. Okay, on the supine view, okay, on the supine view there are distended or dilated loops of the bowel. On erect view there are air fluid levels present, and air fluid levels should be more than 5, if we count it, but there are so many, not only 5, so many air fluid levels are there in any case of intestinal obstruction. Ultrasound scan of the abdomen will show Swiss roll appearance because of the typical intussusceptum, which is going into intussuscipiens. This type of arrangement will give rise to Swiss roll appearance. I have collected one of the ultrasound picture of this. Okay, we'll see that in the next slide. Barium enema, which may reveal the stack of Quine sign, and barium enema is also a treatment here. Now, barium enema is a bit of diagnostic as well as therapeutic. Now, therapeutic in the sense that it will push that apex of the intussusception backward. Now, remember what is happening here? One piece of the intestine or one loop of the intestine is telescoping or moving distally into the distal loop. So what we are doing with this, we are pushing it back towards its original, position. So it may be therapeutic. And similar type of, treatments are done in the management as well. We'll talk about that a bit later. Now, look at this abdominal X-ray. See here, this is a supine view. So I cannot see air fluid level in the supine view, but there are distended or dilated loops of the bowel. See, okay. So these are the ones. I can clearly see that here in the middle part of the abdomen, a little bit on the left side as well. Now this is known as, see this Swiss roll appearance, Swiss cheese appearance. Okay, see that? Okay, typical. So this is the ultrasound view of intussusception. The final part is the treatment. So how we do the treatment or how we manage this type of cases. The treatment of choice is reduction by barium enema under the radiological control. The enema is simultaneously a method of imaging and of treatment as well. Just now we talked about that. We give barium enema, we push this barium enema inside the rectum under X-ray, a radiological control, and that will probably reduce, okay, the intussusception back in its normal position. Another way is hydrostatic reduction with the help of water. Hydrostatic reduction. The water is pushed there with a bit pressure, okay, into the rectum, of course, and we hope that this intussusception will be reduced. About 10% of those cases will recur, okay, if they are reduced in this way. But nevertheless, it is one of the options. Note that barium enema is contraindicated if there are features of perforation or generalized peritonitis. This point is not new to you. Okay, I have discussed this so many times before also. If there is a risk of perforation or already if perforation has occurred, I will never give any contrast material into the bowel because it will leak into the peritoneal cavity and it will further aggravate the situation. A relative contraindication is the length of the history that is more than 24 hours may be too long for barium enema reduction to take. 24 hours is a long time for the ischemia of the bowel to happen. So a high chance of perforation. Now, what are the surgical indication? Okay, those are the conservative management you can talk. But what are the surgical indication? The definite surgery. Child under 3 months or over 2 years. Clinical signs of peritonitis already happened. Gross dehydration in the child and failure of medical treatment or recurrence after medical treatment. Okay, so all of these are different types of surgical indication. So we straight away take the child to the operation room, open the abdomen, and do whatever is necessary there. Surgical reduction has a recurrence rate of about 3%, and resection is said to remove the risk of recurrence. So what the surgeon will do there, they will check whether the bowel is still intact or not. If it is already dead or not, they will make sure about that. Now, a bit of practical point here, how to know that this bowel is still healthy or is still not dead. You just touch the bowel there. If there is a slight contraction, then this bowel is still normal. We can shape this bowel. Okay. Another one is color. The color of the bowel, if it is completely black in color, then probably it is already dead. Okay. And when they cut the bowel, if there is a brisk amount of hemorrhage, then the bowel is still intact or it can be shaped. If all these things are not there, then bowel is dead, and that dead bowel has to be sacrificed. It has to be cut, followed by end-to-end anastomosis. The surgeon will decide right there what to do. So these are the different forms of management of intussusception.